Hello, everybody. Welcome to this masterclass on retinal detachment. In the first class, we'll discuss pathophysiology, Lincoff rule, and prophylaxis. So, we all know the retina is the innermost photosensitive layer of the eye. And here you can see the layers of the retina. And when there's a detachment between the RPE, which you can see in this light blue color, and the neurosensory retina, which you can see here, that's when retina detachment occurs. This is a schematic drawing which shows separation of the neurosensory retina from the RP, and this is the cause of all the trouble, the retinal break. We must understand what are the forces which keep the retina attached in a normal condition. These include the viscoelastic tamponade by the vitreous gel, the hydrostatic intraocular pressure. Also, there's the interphotoreceptor matrix keeping it in place and the suction force of the RP, also known as the RP pump. When retina detachment happens, all this gets disrupted. It can be either regmatogenous or non-regmatogenous, which could be tractional or exudative, or you could have a combined version of all these. In this masterclass, we'll be concentrating on regmatogenous retinal detachment. So this is a big contribution of the master Dr. Jules Gonin, who challenged the dogma and actually told the world that it is actually the break which causes the retinal detachment. He recommended ignipuncture using a red hot searing probe to close the break. And before the Gonin era, there was only 5% success rate. But once this technique started, even in early stages, there was 30 to 40% success rate. So he was really known as the father of retina detachment surgery. If we come to pathophysiology, this is what matters the most, the retina break, which is the full thickness discontinuity in the neurosensory retina. It can be a tear. You can see here. This is due to dynamic vitreous traction, and you can see a big tear of the retina, which is lifting up the vessels, along with the laser around it. Otherwise, you can have holes which can be secondary to localized retinal degeneration or atrophy. And here you have a round atrophic hole and an operculum. It's very important to find these lesions because these are the ones which are going to cause your retina detachment that you're going to treat. So if we come to the pathophysiology, what are the steps in the formation of the RRD or the regmatogenous retina detachment that we are going to discuss today? There's the existence of an abnormally mobile, partially liquefied vitreous, along with traction force to precipitate the break, which you can see in this schematic drawing. This break allows the passage of the liquefied vitreous into the subretinal space, which actually leads to the retina detachment. Whenever we are confronted with this sort of a patient, we must first ask the patient what are the symptoms they're having. So photopsia is something which is very important. So flashes is something you always need to ask for in a patient you suspect a retina detachment. Floaters are also something which a patient often notices because of tobacco dusting, etc. Or a curtain or shadow, because you can see in this diagram how retina is getting detached. So the patient will be having a field loss. Look for this when you're doing clinical exam. The Schaffer sign, the presence of brown pigmented cells floating in the patient's vitreous humor, which is pathognomic. Sometimes you can have RBCs also, so there may be some vitreous hemorrhage because of a bleed due to the bridging vessels getting torn over the break. And of course, you may have a corrugated mobile retina on exam, like we see in the drawing, or RAPD in the acute retina detachment cases. So a good clinical exam is the key. And like Professor Ingrid Kreisig always teaches us, be a good Boy Scout or Girl Scout. Try and make a very good diagram, a large diagram, which is known on the Amsler chart, which is given to you. Try to draw the vessels, and the break should be marked in relationship to these vessels. So these are the features which can guide to the location of the breaks during the actual surgery. So the amount of hard work you do pre-operatively will pay you rich dividends in the OT. When you're doing operation, patient may get uncooperative, the cornea may get steamy. There may be other conditions which don't let you do such a good examination at that time. So let this chart be your guide and have a good chart and pin it up on the wall of the operation theater when you take a patient up for a surgery. So these are the Lincoff rules for finding the causative break, because if you cannot find the break, you cannot treat the detachment and you cannot move forward. So this is a beautiful book which has been put together by Professor Kreisig, and I would recommend all the students to kind of read this book or go through these rules which I'm going to tell you now. So now when you find a RD in this configuration, it can be higher nasally or temporally. Basically it is a superior temporal or nasal detachment. So now 98% chances are that the primary break will be within 1.5 clock hours of the higher border. So first, most important thing is look for the borders. Where are the borders of the detachment? Second thing is look where are the borders higher. And then you'll find that maybe one break or maybe two will be found in the higher border. So this is very nice because instead of having to see a whole retina very carefully for this, of course, exam is very important, but you can be quite sure that if you find a break in this area, then you're actually looking at the culprit break. What about rule number 2? If you have a total or superior detachment that crosses the 12 o'clock meridian, like this situation, then 93% the chance is that it is at 12 o'clock in a triangle and the apex will be at the ora serrata. And it is going to be, if you look at the borders again, supposing the temporal border is a little lower, then it may be slightly more on the temporal side. If the nasal border is a little lower, it may be slightly nasal side. But basically, if you have a total detachment which crosses 12 o'clock, just look up around 12 o'clock meridian. You're likely to find a break there in more than 93% of the patients. What about inferior detachments? So these are inferior detachments are normally not so very bullous. They have shallow fluid. Again, the key is in the looking at the borders of the inferior detachment. And in 95%, the higher border of the detachment will tell you which side the break lies. So please examine the borders of the RD carefully and look where is the fluid going higher, because all these rules are based on gravity, based on the break, and they're all very, very logical. So based on gravity, if it's higher on, the, for example, the nasal side, then there's more likelihood of the break being on that side. What about inferior bullous detachment? Somebody may see this and try to look for the break inferiorly, but remember the rules. The retina behaves logically and follows rules of gravity. So whenever you see a bullous detachment, suspect something is not right. You have to look in the superior quadrant, and there's a teeny tiny break here and a gutter of fluid going down. Sometimes even changing the position of the head may help the fluid to gravitate on this side. Supposing it's a nasal open and you put the patient down nasally, the fluid may gravitate here, and once the fluid comes around the break, you'll see it opening up. So what is very important is spending a lot of time doing the initial examination of this patient. Don't be in a hurry, because finding the break is really the key to a good surgery. What about prophylaxis? Now, this is something which is very, very important because there's a lot of debate on this topic. And we have very good guidelines which have been given by the American Academy of Ophthalmology on prophylaxis of retina detachment and of these lesions which can occur, which can be precursors to retina detachment. So the million-dollar question is to observe or to treat. The risk of a fellow eye getting a detachment is roughly about between 5 to 10%. And 70% of the tears after the PVD, please remember, occur in the apparently normal area. So this always treating such lesion may not really work, and this may be away from the predisposing lesions. And 89% of RDs in untreated eyes with 2 or more risk factors appear in these areas because it's the PVD which is responsible. So these are the kind of guidelines which are there. This is the current practice from the American Academy of Ophthalmology, which says if there's an acute symptomatic horseshoe tear, this is the number one thing, or acute symptomatic dialysis. These you must immediately treat. There's no doubt. No, there's absolute consensus on this. If there's an acute symptomatic hole, then treatment may not be necessary, but can be considered. If they're traumatic retina breaks, we usually treat them. But if you see this whole list about asymptomatic horseshoe tears, asymptomatic holes, asymptomatic atrophic holes, or asymptomatic, most important, lattice degeneration, with or without holes. Usually, these do not warrant treatment. So, I think it's very important that these people are given what we call passive prophylaxis, which we are taught by Dr. Price. They're told about signs of detachment. They're told that if they get flashes of light, if they see thousands of small floaters, if they see a black curtain in any field of the eye, then they must come immediately to us for checkup. But we don't really need to unnecessarily treat them. So again, if you go through this slide, if they want to see the evidence-based, strong evidence always is symptomatic flap tears. But other things we don't need to really treat, but keeping a very close watch may be important. And symptomatic patients always keep a close watch, irrespective of what happens. Even if you treat it, you need to keep a close watch, see them after a couple of weeks, and then add more laser if required. I think that's very, very important. And why is this so important? Because this is the reason why the symptomatic tears happen. There's a vitreous gel which is actually pulling and tearing the retina, and there's traction. So I think the key is the traction which causes the tear and which needs to be addressed, because these are the ones which go on to become retina detachments. How will we treat? Once we decide to treat, you can either do cryotherapy around this, or most importantly, today's era, we do laser. We can do laser around the lesion. We can do more laser. It is a personal choice. Or if there's a dialysis or subretinal clinical RD, then is the case where we might do a buccal or a pneumatic retinopexy, which we'll be covering in the future modules. So thank you so much.